Good afternoon, everyone, and welcome to today's event, Health as a Weapon, Gaza, Syria, and the wider MENA region. My name is Marwa Daoudi, and I'm the Saif Robash Chair in Arab Studies and an Associate Professor of International Relations at the Center for Contemporary Arab Studies at Georgetown University. I apologize in advance for my voice. I'm just out of a flu, and hopefully it will be sustained throughout the event. Today, I'm very, very pleased to introduce Salma Daoudi, who is our last speaker of the semester in my class on critical environmental and human security, where we have been listening to a great line of prominent rising voices from and on the Arab world. Salma Daoudi is currently a DPhil candidate in international relations at the University of Oxford, specializing in international security and global health with a regional focus on the Middle East and North Africa. Her dissertation is on regional health as a regional human security threat and the weaponization of health in Syria. Her research primarily revolves around, as I said, the weaponization of health, but also its repercussions beyond the focus and temporality of violence. Salma is also a non-resident fellow at TIMEP and a researcher within the ACCEPT local research network on cross-border conflict. She has previously worked as a researcher and policy analyst, focusing predominantly on human insecurity in asymmetric warfare, the security development nexus, and more broadly, MENA geopolitics. As I mentioned, this talk is taking place in the context of this graduate class on critical environmental and human security, where we have been discussing and studying issues close to Salma's line of research, namely historical climate injustices with a focus on Palestine, amongst others, food, water insecurity, and the weaponization of resources and infrastructures, water, energy, and food, in the context of armed conflicts such as Syria, Yemen, as well as in the context of the genocide currently taking place in Gaza and the war launched on Lebanon. Today, we will more specifically hear about another weapon wielded against civilians, the health sector. Salma will begin with a presentation on the topic, and then I will ask a few questions, and the students also will be asking and intervening. And then there will be time also for questions from the audience afterwards. If you are joining online, please enter your questions using the Zoom Q&A feature. If you have any technical issues, please email our wonderful events and program manager, Coco Tate, who has been organizing all of this event like usual, very professionally. This information will also be in the chat. With this, I give you the floor. Please start, Salma. Thank you.
Thank you so much, Marwa, for kindly inviting me. It's such an honor and privilege to be joining you to present some of the research that I've been conducting, and unfortunately a topic that is quite so timely. I'm just going to start by sharing my presentation, and as I do so, I really wanted to first start this presentation by emphasizing the importance of historicizing and contextualizing trends and patterns in IR, including obviously the weaponization of health, because the two contexts that I'm going to be talking about in this presentation are obviously quite different. And so I just think that it's very important to remain kind of grounded and ensure that we know that when we're talking about Syria, we're talking about the weaponization of health in a context that is marked by a counter-revolution, authoritarianism, and we're talking about Gaza, we're talking about occupation, ethnic cleansing, and genocide. But the weaving thread that sort of joins these two conflicts and demonstrations of violence is obviously the asymmetry of power that is marked in both cases, either between the oppressor and the oppressed in Syria, or the colonizer or the colonized in the case of Gaza. And this explains why we have this sort of violence that is exercised on populations. So I'm going to start this lecture very briefly by going over the need to redefine security and kind of the place that health should hold whenever we're talking and conceptualizing security in modern conflict. And then talk a bit more about how I'm theorizing the weaponization of health, because there's been a lot of work that's been conducted on the weaponization of other public goods, including food and water. Obviously, as Marwa is a brilliant example of the work that has been conducted on that front. But when it comes to health, the concept still lacks a lot of theoretical grounding. And conceptually, it has always kind of been limited to material destruction of infrastructure. And so I'm trying to conceptualize a broader typology that looks at how this is a deliberate yet still almost surgical assault on not only structures but also conditions that sustain life itself, and that are not quite captured by the literature. And obviously, as I do that, and as I move forward with the lecture, I'll be drawing from patterns and trends based on the research that I've conducted, based on interviews that I've conducted, because a large focus has been on sort of how to elevate narratives of individual health and security for me. And so I'm going to try to draw from that in order to illustrate the trends and patterns that I'm going to be discussing. And then I'm going to look at the strategic rationale that underpins the weaponization of health in both a context of counter-revolutionary repression and then in a context of occupation and genocide, before sort of moving to the erosion of norms and the normalization of international humanitarian violations, because in a lot of ways, what we're seeing today unfold in Gaza has been facilitated by impunity in Syria, impunity in Yemen, impunity in Sudan. So to first start maybe by re-emphasizing the importance of, quite frankly, adopting a more multidimensional approach to security. Obviously, there has been a lot of work that has been conducted on that and on the need to go beyond orthodox conceptualizations of security that just look at the state as the main kind of threat and referent object when it comes to security. But it's important to constantly reposition the individual at the heart of it. And health, like food, water, and shelter, isn't just a matter of wellness or well-being. It is integral to security. It is integral to survival. It is integral to people's ability to live a life that is dignified. And so health in that sense is a core and interdependent component of human security because it shapes and is shaped by other factors. So to rapidly explain maybe what I mean by that, when we're talking about food insecurity, about famine, starvation, this directly impacts health because it creates new health vulnerabilities, it aggravates pre-existing health conditions, it leads to death, etc. So they're very much deeply intertwined. Same goes for economic insecurity, poverty that restricts access to healthcare, but also aggravates people's health risk factors. So on an individual level, we're looking at how the lack of medical care and how people's health risk factors directly threaten the longevity and quality of life of populations in ways that can, of course, be either lethal or severely debilitating. So when we're talking about, obviously, these deaths, there are protracted deaths because they result, for instance, from the lack of access to dialysis for patients with kidney failure, from contracting infectious diseases, having them develop and lead to death, etc. And these deaths are not directly related to an overt form of violence, but they stem from the deterioration of living conditions in times of violence. And we can see this, for instance, in Syria with the cholera outbreak in 2018, with polio before that, and now as well in Gaza, where there's a rise of infectious diseases, a resurgence of polio. And the deaths that might result from these are usually called non-violent deaths, which I think is a euphemism that can and perhaps should be contested and resisted, because these deaths, one might argue, are at the contrary the very product of violence, as they reflect the sheer scale of damage that is inflicted to institutions, social fabrics that sustain livelihoods. And so when we say non-violent, we kind of obscure the violence that is behind these mechanisms. At the same time, just focusing on death and mortality is fairly limited as a metric because it doesn't take into account the injuries, the disability, the chronic conditions, and the permanent scars that people can carry from violence and war. And they're very important to kind of also inscribe at the heart of the security agenda, because this drastically changes people's lives and alter their future, alter their autonomy, their capacity to be productive members of the society. So this is on an individual level. On the collective level, I think this argument is no longer controversial after COVID, but we've seen that in addition to increasing death and disability rates, public health crisis nurture fear, deplete national resources, increase competition for scarce medical access, and jeopardize social and political stability. They trigger economic crisis. So there are heavily intertwined as well with stability and security. So in that sense, what I'm arguing is that we need a fundamental redefinition of national and collective security that posits public health itself as indispensable for collective survival, that situates health security at the heart of the security agenda instead of its margins. So health would then be seen as a domain where power as well is contested and as a site of suffering. And to theorize that, it's important to kind of look at how war and armed conflict more broadly act as disruptive forces. They're shaped by historicized and localized politics, as I mentioned, because they compromise in specific ways social institutions, and they deregulate essential components of physical and mental well-being. And the asymmetry of modern conflicts, and again, this is the case in Syria and Gaza, blurs the line between combatants and non-combatants in ways that anchor the omnipresence and omnipotence of violence. So violence is no longer exercised in a localized way or against specific groups. It becomes sort of embedded in these collective punishment mechanisms where the entire population, regardless of political affiliation, regardless of personal sympathies, and again, we can talk about whether or not these are, to begin with, punishable offenses, but people are simply caught in the crossfire because the war is waged against them, and their bodies become a battlefield and a site of conflict. So they're exposed to both overt and covert forms of violence, overt because of indiscriminate bombardment, violence, arbitrary arrests, etc., but also covert forms of violence because there's this institutionalization of structural violence when social structures and institutions prevent people from meeting their basic needs. And so this sort of radical security assemblage utilizes various forms of violence to murder, discipline, and deny inhabitants the socio-material cityscape of their environment, and it shrinks the politically, socially, and biologically viable urban spaces. And so that's why I'm using a biopolitical and necropolitical lens that posits the state in the case of Syria or the occupying force in the case of Gaza as kind of both the giver and the taker of life. We're seeing how these actors try to exert control over populations through the regulation and the dysregulation of life and death. And so this is evident in the way in which health systems are strategically manipulated to determine who receives care and who is left to suffer or to die. And so that's why we see kind of that access to care that is restricted, how diseases are weaponized to inflict suffering and death on populations. So these frameworks kind of reveal the duality of health weaponization as a strategy that both manipulates life for control, but also enforces death as a form of domination. And it's quite intimately interlinked with the exercise and the expression of sovereignty as well, because it can be articulated by state actors that are attempting to reaffirm it. So this is the case of the Assad regime as it tries to kind of reaffirm its right to control who lives and who dies when its rule has been threatened. Non-state actors also attempting to claim that sovereignty by sometimes establishing alternative governance models and systems to provide healthcare, or occupying powers attempting to delegitimize and erase any possible kind of expression of sovereignty. So there is obviously some research that has been conducted on the relationship between health and security, but the focus has oftentimes been on non-intentional or incidental consequences of conflict on health. And so the strategic use of health has been overlooked despite very frequent and mediatized targeted attacks against health infrastructure and personnel. There definitely is a resurgence of interest lately, given the amount of attacks that have been conducted in Gaza. But starting 2011, Syria has been the site of very violent and high number of attacks against clinics, whether makeshift or official, and this has failed to garner that much political or academic attention. And so that's why the concept still lacks a lot of conceptual and theoretical grounding. And so what I've tried to do through looking at data sets compiled by Physicians Against Human Rights, by the Syrian Archive, through interviews with Syrian healthcare personnel, Syrian humanitarian workers, Syrians who've been displaced to either Jordan, Lebanon, is to try to develop and construct a comprehensive typology of the weaponization of health that broadens the scope and engages with coverage and overt forms of violence. And obviously, this is a very broad spectrum. These strategies have oftentimes been used simultaneously, but it doesn't always has to be the case. And a lot of these strategies, a lot of these patterns, we're also seeing now unfold in Gaza. But obviously, they remain linked to hyper-volatile and local conflictual dynamics, so they're not necessarily very heterogeneous. But essentially, and I think this is the main contribution of this lecture maybe, and I'm looking forward to knowing what you think about it and how you kind of perceive these different facets of the weaponization of health. But essentially, the two boxes in red are tactics that undermine health from a demand perspective. So they create health vulnerabilities, and I'm going to talk about each in a second and provide examples of what that looks like on the ground. And the ones in orange are more about undermining health supply. So by restricting the accessibility and availability of medical services or conditioning them on political allegiance, racial affiliation, social affiliation, etc. So the first one kind of looks at the production of medical mass violence, which is often left out from conversations on the weaponization of health. So this focuses, and it might seem quite counterintuitive, on the contribution of health personnel to the production of mass or localized violence by volunteering their medical knowledge to either state-sponsored, or non-state armed groups, and using it to inflict harm and support military and political objectives. And when we're talking, for instance, about the militarization of healthcare, we're talking about the relationship between military and medical spheres, and how instead of primarily serving the people, the population, public health interests, militarized medical corps lend support to sustaining and improving the efficiency of military performance by, for instance, diverting public healthcare resources towards the military, adopting triage methods that prioritize the military over civilians, and sort of establishing and institutionalizing a medical negligence policy at the disadvantage of the population to the benefit of specific nodes of power. And of course, it doesn't necessarily mean that doctors are voluntarily engaging in that. There is obviously that with doctors that are affiliated, for instance, in Syria with the Ba'ath Party or with the military, but it's also sometimes forced upon them. And this is something that I've sort of seen a lot through the interviews that I've conducted of a lot of doctors that were forced to prioritize, for instance, saving or providing healthcare to army officers injured in clashes and tensions, and then being punished or detained or tortured for not being able to save those lives. And so this is kind of a subversion of public health governance to produce mass violence. We're also seeing health personnel, for instance, in Gaza, or more broadly in Israeli detention centers, Israeli prisons, misusing their medical knowledge to actually exercise harm, to prepare for torture, to participate in torture as active torturers, or to sometimes fail to report torture, to falsify forensic reports, to suppress the truth. And this has been the case for a lot of Palestinian detainees who've reported repeated physical and psychological torture from health personnel even before last year. So this predates the 7th of October. And in the case of Syria, this has been mainly perpetrated in military hospitals, in Homs, or in Damascus, or in branch 261 of the military intelligence services. The second type is more about how actors can directly or indirectly undermine access to basic necessities. So by restricting access to food, water, other basic necessities, by engineering the scarcity of resources through embargoes on humanitarian aid, through siege warfare, through the deliberate destruction, for instance, of water facilities, sanitation services, these actors are weaponizing health by actively exposing populations to additional health vulnerabilities, and sieges and restricted access due to humanitarian aid in Syria, where we've seen that the same regime whose violence creates an acute need for relief can distribute aid in a way that compounds the suffering of the population it exercises violence on, by diverting aid, sometimes to the benefit of the military, the party, or simply populations that continue to display a certain level of regime loyalty, and withholding it from population that it deems unworthy of lives, or that it seeks to punish or discourage from dissenting. And there are several examples of seizures that we can mention, either in Aleppo, Yarmouk, Idlib, and obviously how this is also intertwined with the international community's failure to provide relief, because most UNSC resolutions for cross-border aid are under the threat of the Russian veto. In Gaza, similarly, there's been a complete blockade of the north, multiple restrictions on humanitarian aid entry, which has engineered a famine that has led to the death and the starvation of many dual-use items that are removed, even in the very few trucks that are able to enter the strip. And with that, obviously, the use of scorched earth tactics, targeting agricultural lands, bakeries, etc., to truly decrease the supply of food that is available. Same when we're talking about the destruction of water facilities, the disease that spread the most in Syria over the past year, cholera is essentially a waterborne disease. And so it's important to emphasize how that restricted access to clean water has played a major role in facilitating the spread of the disease. When it comes to restrained access to health infrastructure, this is the category that is most prominently featured in the literature. And we're talking about the overt targeting of this and destruction of civilian infrastructure. But I'm also looking at other ways of obstructing and constricting access to health services through not only targeted destruction, but also the subversion or administrative and military encirclement of health infrastructure. So targeted destruction, obviously very high levels of attacks in Syria between 2011 and 2022, the highest rate of attacks recorded with over 600, and those are the verified attacks that have been kind of documented. And there's been a concentration and recurrence of attacks in the areas that were besieged by the regime, who with Russia is responsible for over 94% of the attacks that have been conducted against health facilities. And obviously, especially following Russia's intervention in 2015 because of the technological capacity for surgical strikes, because of the subversion of the confliction mechanisms to strike hospital coordinates. For those of you who are not familiar with the confliction mechanism, it was essentially a UN-led initiative for doctors, healthcare personnel, health authorities to share their the coordinates of their hospitals, so that the sort of the Russian-Syrian alliance would not target them. But it was later found that those sites were very much the ones that were targeted, even though they were on a no-strike list. And in Gaza, we've seen that just over the past year, there has been close to 500 attacks on healthcare facilities, close to 100 in Lebanon. And this really points to sort of the normalization of these attacks as they continue to increase. And when we're talking about administrative or military obstacles, it's more about checkpoints, curfews, other administrative measures that are set in place to restrict freedom of movement and to hamper access to healthcare services. In Gaza, the permit regime, so people having to ask in order to be able to exit the strip because there hasn't been a lot of specialized medical care available, often find themselves kind of under the power of Israel, who determines whether or not they're able to leave the strip. And a lot of these requests are routinely denied. Criminalizing medical neutrality, this is kind of another way of crippling health systems by criminalizing de jure or de facto medical neutrality, actively targeting health personnel. So this includes subjecting health workers to abduction, torture, imprisonment, something we've seen on a very large scale recently in Gaza. In Syria, there was also the 2012 anti-terrorism decree that essentially outlawed the provision of health services to those that were deemed to be enemy of the state or to anyone who might be affiliated with the opposition or seen as sympathetic to the revolution. So essentially outlawing medical neutrality because doctors do not even have a way of sort of knowing what the person's affiliations are. And the last kind of facet that I want to talk about is also about how sometimes non-state actors can build healthcare infrastructure to try and legitimize themselves or to try and win the hearts and minds of the populations that they want to gain over. And so this is also sometimes a pillar at the core of state building projects, but sometimes it can be used in a way that is conditional upon political allegiance or conditional upon religious allegiance, because this is kind of, this was a core pillar of ISIS, of trying to sort of provide social services to guarantee people's allegiance to the group. So very rapidly to kind of talk about the strategic rationale that underpins the use of health as a tool of war in these two contexts. We're talking about Syria. We're talking about a war that has unfortunately permeated everything, and the sort of space of the war has become that of the life of the masses itself, of the people, and we've seen kind of zones of death and life merge because the state of exception has been so expanded that everyone has sort of been deemed to be antagonistic and a potential threat, which is why we talk a lot about kind of indiscriminate violence. And so this everywhere war is kind of a conceptual and a material project that not only kind of reshapes social life, but also replaces the battlefield with a battle space that has no proper delineation. And the nature of that meant that there were incentives to produce mass violence in order to not only increase the chances of eradicating any opposition, but also to dissuade civilians from supporting any opposition groups. So cities have emerged as kind of strategic sites of political violence, and they've been deeply reshaped by acts of violence that permeated everyday spheres of life and that have crystallized these geopolitical struggles in people's everyday life. So we've seen kind of the production of mass death and disability in an attempt to obviously spread terror, but also secure tactical gains through forced displacement, demographic re-engineering, more importantly, to undermine resilience and resistance, so discouraging, but also trying to eliminate dissent, eroding the social bonds that were necessary for collective resistance, jeopardizing the viability of any alternative public governance model. When we look at the number of attacks that were, for instance, conducted against makeshift hospitals or underground hospitals, we're seeing that sort of any possible competition to the state's monopoly on social services was very rapidly eradicated. So the strategy wasn't just punitive, it was also performative, and kind of sending a clear message that health is not a right or neutral, it's a privilege that is granted or withheld at the will of the state. Under occupation, we're seeing also this repeated targeting of crucial lifelines in Gaza, and it serves obviously several objectives: the production of mass violence, because we're clearly witnessing a genocide to inflict casualties at a large scale by destroying hospitals, by creating health vulnerabilities. The IDF is able to produce much more death than through, for instance, bombing by themselves. So this is kind of adding to the already important level of violence that people are suffering from. This is weakening civilian resistance, resilience, ability to survive. This is an attack on their right to health and the right to exist. And this is also leading to the forcible displacement of populations. And quite frankly, crippling any possibility of a Palestinian future even. We've seen that Gaza now has the largest pediatric amputee population in the world. So that means that a lot of children have been stripped of the future that they've been dreaming of. They've been stripped of their capacity to be productive to their societies. There's been an assault on reproductive care, lots of death of newborns and lots of miscarriages, etc. So we're seeing that through its genocidal, herbicidal, and ecocidal actions, Israel's violence has effectively ensured that all remaining life in Gaza is irreversibly damaged for generations to come. And very rapidly, to kind of close and leave room for questions, I'm just going to talk about how this erosion of norms that we've seen in Syria a decade ago, that we're seeing now in Gaza and in Lebanon, that we continue to see in Sudan as well, where there's a mass public health crisis. The frequent targeting of hospitals, of healthcare personnel, of ambulances, and it being sort of justified through a rhetoric of terrorism or counterinsurgency, etc., has rendered these violations almost routine. creating what we called a threshold of acceptability. So these violations have become so normalized that they're less likely to actually provoke outrage or enforcement. And we're seeing how the international community is struggling to enforce accountability, oftentimes due to geopolitical conditions and considerations, but the result is a regime that implicitly permits the slow erosion of health in ways that are, quite frankly, both manifest and covered. And so the means of sort of collectively punishing a population, discouraging it, betraying any form of resistance, whether peaceful or violent, is obviously contradicting the basic tenets of international humanitarian law. It's perpetuating structural power imbalances. It's instilling fear and physical as well as psychological trauma. Yet we're seeing that it continues to be instrumentalized to render cities inhabitable, inhospitable, hostile. And I think this is why we should also maybe think of accountability as not just a collective responsibility, but also as a public health emergency to sort of stop the public health crisis and the protracted deaths that continue to result today from these different actions.
Thank you very much, Salma. This brilliant presentation. Would you mind stopping the screen sharing so that we can see you on the screen? I just want to say how fascinating and also how what a darker picture even more than what we know about what is happening now in Gaza and in Syria as well. But I thought it was very interesting the way you have an agenda to redefine the meaning of security and the fact that national security should not be defined only in militaristic terms, but also to include health as a major component, which is a struggle, right? Because it tends to be sidelined in all of the discussions, even when there are talks about putting human security as part of national security. I very much appreciated also your redefinition of health weaponization, which is often used, but not conceptualized the way you do it, and how it's not just collateral damage, right? It's deliberate assault and a deliberate weapon of deterrence as well, preventing the wounded from being saved so that the death toll increases, but also the consequences are very dire for the society. And that there's no such thing as protracted death as sort of a collateral damage, right? I also appreciate your focus from the biopolitics and necropolitics side, how the occupying power, how the authoritarian regime wants to destroy the living, moving body, but also the dead body. Even when they're dead, they are being controlled and destroyed and erased somehow as well. I had a question about actually your typology, and I think it's very important to have a typology here. We tend to have a typology on water weaponization, food, but not on health, as you mentioned. My question would be, is there is a deliberate targeting of the health workers as well, not only the infrastructures, right? We see it, Israel doing it in Gaza, but also in Lebanon, in the current war in Lebanon. It seems to me this is as much as a supply as a demand aspect. Have you considered categories which overlap between the two? And I'm just trying to think of a way of including as many of these tactics as possible. And then my other question is, tactics are short-term, sort of, performative or decisions implemented. But what is the strategic goal here by having this focus on the health sector? Would you say the broader strategic goal is ethnic cleansing? Is it de-development? Have you thought about the broader strategic objective behind all of these aspects?
Thank you so much, Marwa, for your feedback and for your questions. I think these categories definitely overlap. When we're talking, obviously, about criminalizing medical neutrality and attacks on healthcare workers, this obviously produces death, but then also reduces the accessibility, availability of medical care. And similarly, for instance, even when we're talking about the targeted destruction of hospitals, the bombing in itself does create a lot of death and injuries, and that in itself, obviously, for instance, in the case of injuries, those are people that need to be treated by sometimes overwhelmed and quite fragile healthcare systems. I'm not sure I'm going to sort of keep those labels as neatly separated, because I think that they definitely intertwine. But I just think that it's a good first step to at least sort of be able to compartmentalize and think of each kind of facet as a distinct but not fully kind of removed strategy, because essentially it's so pretty much enmeshed together, and they're just different facets of the same attempt to attack life and produce as much violence as possible. When we're talking about kind of the strategic rationale, I definitely think in both cases, it is the production of mass casualties and mass death. But then the specific purposes as to why would obviously differ. In Gaza, this is inscribed in a broader genocidal project. And in Syria, it was more about sort of punishing or dissuading people from even defending. Also forcible displacement to kind of demographically re-engineer areas that, for instance, that were later on replaced by more loyalists or affiliated militias. It's also about sort of trying to perform violence in a way that is not just punitive, but also dissuasive, but that also reaffirms the state as a state. And I think that was very important in the case of Syria because of the challenges on sovereignty, and then just kind of like spreading terror and making sure that some tactical gains were secured, especially once the regime sort of started gaining back more territory, and trying to kind of really ensure that any viable option and alternative of public health governance model would not be able to be sustained.
Interestingly, here the state is the provider of insecurity in the end, although it pretends to be the provider of security, right? Like it's this very dual aspect, which is very perverse, I think, in the case of in Syria, actually, where you have both aspects like unfolding at the same time. Yes, thank you, Salma. I'm going to take questions from the audience, from our students, and I invite the online audience to submit their questions in the Q&A box on Zoom. And who would like to ask questions? Yes, Siv, Mariam. Yes, I'll start with Siv. Go ahead.
Hi, thank you so much for coming in. I hope you can hear me well. I was wondering about one of the points you had, which I found super interesting, which was accountability as a public health emergency. And I was wondering what concrete actions do we need to see also coming from the international sphere? Because we always see, you know, we condemn whatever action, strong words, but then no follow-up. So what is kind of the mechanism you would like to see, or what should happen on the ground to actually change that?
Mariam, do you want to follow up?
I actually was also going to ask a question about the idea of accountability as a public health emergency in the context of Israel banning UNRWA, as well as Israel essentially negotiating with the WHO to figure out a period of time where they can vaccinate for polio, which has also been an issue in Gaza lately. But my question was, as accountability is more of a sentiment than a tangible action these days in the international community, Similarly, I guess you can honestly combine our questions. What do you anticipate or what do you suggest is done in the field of public health, so long as this accountability is abstract rather than something that is actually being enforced?
Yeah, thank you so much for your question. I think the way in which we can, so maybe I'm going to actually start with the second part of the question about kind of accountability being more of a sentiment. I think it's important to sort of have a clear pathway towards achieving justice. And in a lot of these cases, what we have are clear violations that are clearly condemned by the Geneva Conventions, that are clearly condemned in international humanitarian law and international law. And so there are clear sort of charges that can be brought up. And these mechanisms have already kind of been somewhat put into play when it comes to Syria. For instance, we've seen the trial of a doctor who was involved in perpetrating torture in the hospital, military hospital in Homs in Germany. Those instances are obviously so scarce and rare and insufficient. But that shows that it is possible to hold perpetrators accountable when it comes to sort of specific violations against health. So I'm not talking necessarily about the rest, but also when we're talking about health, we're also talking, for instance, about the use of chemical weapons, right? Because that also directly creates a lot of health vulnerabilities, not only immediately, but also over the long term. And those are also kind of punishable offenses that can be raised in international courts, but also now, as we've seen with the case of Ala Musa, the doctor that was in trial in Germany, also in other countries that can act as well via their tribunals to establish a sense of justice.
If there are no questions, I'm going to follow up with a question, Salma. There are terms which have been conceptualized to really capture when there is a deliberate assault and destruction, mass destruction of people, deliberately with the intent of destroying them. This is genocide. And we've seen that in the case of Gaza, it's been ruled as a plausible case of genocide by the ICJ. A lot of the experts on genocide refer to it as actually a textbook of genocide. When it comes to the environment and to critical infrastructures, we have the term ecocide. Is there a term when health is being targeted? We know that, for example, schools, there's been this ongoing term of scholasticide, urbanicide, etc. When it comes to the health sector, I haven't really seen, but perhaps I've missed it. What is your knowledge of that? Or is that something, some work in progress that should be done, actually?
Oh, that's actually a very interesting question. I think there is no proper term so far, at least for that, because usually it would either be inscribed in herbicide, so with the attacks on critical civilian infrastructure, because the destruction of hospitals, even though I think that that is fairly distinct from attacks on other civilian infrastructure. Or I think more broadly, that is also part of the way in which we understand genocide today, because this is essentially an assault on life. And if it doesn't create necessarily death immediately, it does foster conditions that are conducive to death. And even when it doesn't, it is still an assault on life because it alters people's lives, and it cripples their ability to actually have a healthy life, to live in dignity, to have full body autonomy, etc. So I think it's definitely interesting to maybe see how it can be further conceptualized. But I think the way in which I understand it would definitely be closer to just simply being considered part of genocide.
Maybe it should be added to the definition, right? Like in that sense, that would be an interesting way of pursuing that agenda, that research agenda. So I have a question from the audience, from Ninar. In many parts of Syria, we have seen civil society rise up to the occasion and provide healthcare to civilians in the past 13 years. What do you think are the pros and cons of localized, non-state provided healthcare? And then there's a follow-up just from Ninar as well, just wondering what the future of healthcare provision is in conflict areas. And then I'll follow up with another question afterwards, please.
Yeah, thank you so much for your question. I think there has been a lot of efforts conducted by the civil societies, by local NGOs to kind of fill that governance void, especially, for instance, in the Northwest, either in Idlib or in northern Aleppo, also in the Northeast. And these NGOs have been trying to essentially fulfill the role of what traditionally would be the role of the state by providing healthcare. Now, obviously, they are themselves facing a lot of constraints politically, because they're still kind of dealing with cross-border aid challenges, because most of the medical supplies that they're bringing in, or sometimes the medical personnel, etc., come, for instance, from Turkey. So that is also kind of sometimes at the whim, right, of either Turkey or Syria. The crossing is not always guaranteed. There are efforts to obviously build capacity locally, but that requires a lot of funds. And sometimes these projects are not funded by international donors because they don't want to be affiliated, for instance, with HTS in Idlib. So they don't want to fund necessarily proper public governance projects or public in infrastructure. And at the same time, it is such a big, I think, responsibility on the shoulders of underfunded and understaffed organizations that surely have risen up to the challenge. And the health gains that were made in the past few years, the progress that has been made is quite simply spectacular and very much to be commended. But they're still facing a lot of financial, I would say, political obstacles, in addition to continued targeting of health facilities sometimes, and in addition to kidnapping, which is pretty much targeting a lot of doctors in the Northwest, because they're sort of seen as the ones with the highest salary, so as targets for ransom. So I would say they're pretty much still heavily challenged.
There is a follow-up question from the audience on Syria, but also Gaza, from Muhammad. Thanks for the very interesting presentation in addressing the similarities and differences between attacks on health in Syria and Gaza. And it's more of a comment than a question, but maybe you can weigh on that perspective as well. Muhammad thinks the political battle is very similar when it comes to attacks on health in both contexts. You just switch the names between Israel and the Syrian regime, between their international allies, the US and Russia, and you will get the same pictures, same media tactics, same statements and responses. While one of the very obvious differences is the appetite that the Syrian regime has to use medical aid as a punishment and reward to the Syrian communities based on their position towards the government, and also the use of medical aid as a support to the frontline hospital where the Syrian army is fighting instead of supporting affected communities. What do you think, Sam, in that sense? The idea that they're very similar, but the Syrian regime is even going one step further.
I definitely think that there are lots of similarities and commonalities, and thank you so much, Mohammed, for pointing that out and further emphasizing that, because I think that was also one of the main points that I was trying to make, is that even though the organization of health is highly context dependent, there are also a lot of commonalities and similar patterns. And yes, when we're talking, for instance, about media tactics, there is a very similar rhetoric employed to justify those levels of violence. Right, the presence of possible terrorist groups hiding in hospitals, that was seen in Syria, that was seen now in Gaza as well. That ambulances are used to transport weapons, that was also seen in both cases. That doctors are actually working as fighters. So there's been a lot of similar, I would say, rhetorical violence or attempts to justify and legitimize these. And when it comes to the fact that the Syrian regime uses medical aid as a punishment and reward, I think that is indeed the main difference, is that we're talking under authoritarianism about an attempt to preserve the state. So the regime is vying for state survival. It is not an occupying power, but it is trying to survive by any means possible. And so that means that, of course, there will be some tactics that are used to destroy, but also some tactics used to kind of try to use that sovereignty in order to just decide how to reward populations that would continue and remain loyal to the regime, and those that aren't necessarily. And again, which is why I talked about forcible displacement and demographic reengineering, because that is much more relevant to the Syrian case than it is in Gaza, where complete annihilation is still on the table and not fully discarded as an option, because again, we're talking about a genocide, and I think that's kind of the broad difference between the two.
I have another comment from the online audience about the question previously raised. Can we conceptualize health similarly to genocide or ecocide? We have Raed, who says the UN Health Rapporteur urges the world leaders to mobilize power to end the ongoing Gaza genocide. Tialeng Mofokeng describes Israel's widespread systematic attacks on healthcare workers and facilities in the occupied Palestinian territories as medicide. So that could be a way possibly to think about it as we all move forward in thinking about these topics.
Mm-hmm.
I'll turn now to the class, and yes, I'll take 2 or 3 questions, Marwa and then Zaina.
Thank you, Salma, for your wonderful presentation. In this class, in the past, we've talked a few times about the neutral nature of humanitarian organizations or the international community, and the paradox of it, and how there is like a delivery of aid, but there is no comment about like the political conditions that warrant the aid. So, of course, humanitarian aid, it may not be right to categorize it under this like topology of health weaponization, but I was wondering like where you see it in, if you see it in your conceptualization of health and even weaponization. I mean, of course, like the last aspect, like building health infrastructure, or, you know, like masking or putting this band-aid. I was wondering, could these like new concepts be a way to problematize the neutrality, or do you see it as a separate kind of framing?
Hi, thank you so much for this presentation. My question is also related to like humanitarian and international organizations. Last week, we focused on like food security, and we've read on like how ideas of like resilience now have like been kind of like institutionalized by like humanitarian organizations. They like promote people just become people in humanitarian or conflict like situations to become like resilient and to basically like essentially like deal with it instead of providing like real like actionable like aid over like a long period of time. So I'm wondering how this has applied to health recently. Like, have we seen this kind of transform? Especially, I think of like the case of like Gaza. Like, I think what like post like once like the genocide ends, how will people, for example, have like lost their limbs, lost like like lost their limbs, like be integrated like back into life? How will things be accommodated for them? Will they expect to just like be resilient, accept this as part of their lives, or will they be like actionable effort to kind of address, because it's like I think Gaza has like the highest proportion now of people with like limb differences because of the
Amputee children as well.
Amputee children, yeah.
We can't hear you, Salma.
Sorry. To maybe start with the first question about kind of building or providing healthcare. I'm talking specifically here about how that provision sometimes is conditioned upon political allegiance or some sort of political affiliation. So this is not the case for, let's say, any sort of opposition in the Syrian case, or for local and bottom-up initiatives to provide healthcare, as has been the case in Idlib, for instance, with the health directorate, which is kind of a bottom-up and locally led by doctors initiative to provide health. I'm more talking about how it is sometimes inscribed as a state, as part of a state building project. So mainly referring, for instance, to ISIS, as I said in the presentation, where access to the health facilities that it managed to provide health care services through was used in its propaganda to try and attract populations, because a lot of people who were living in other cities, for instance, were not able to access care. And so that was sort of, it's part of toolkit to attract more people. But then also for people who were, for instance, in Raqqa, when the city kind of fell at the hands of ISIS, accessing these facilities, these hospitals, was only possible if someone was really known to be kind of loyal and affiliated and ideologically committed to the group. So it is this conditionality that I think subverts and weaponizes health, because it's not open to everyone. And even in areas now that have been gained back by the regime, we're seeing this selective kind of provision of healthcare services, right? Because of the geographic distribution of it. So it is only available fully in certain places. Basic services have not been restored all across the board. When it comes to dealing with the future of people that have been disabled by war and violence in the context of Gaza, I really think that there needs to be a lot of work and effort going towards that, because especially for kids, beyond the physical disability, this is also a permanent reminder of the violence that was inflicted on them, psychologically, trying to survive in an environment as hostile as Gaza now, under occupation, under genocide, with complete lack of access to accessibility pathways or mobility facilities, etc., no rehabilitation centers, etc., is almost a death sentence for many, or at least it is significantly stripping them of their capacity to survive or to live. And it's also the transition, from being able-bodied to being disabled that is very hard, and that requires a lot of psychosocial support that is unfortunately unavailable. It also requires a lot of community care, family care, but a lot of the kids, unfortunately, today in Gaza that have been maimed or that have been disabled have also been orphaned. They don't necessarily have extensive support networks that they can rely on to be taken care of. And so I think that in the coming years, we're really going to see kind of the testing of solidarity networks in Gaza, because of the impossibility to care and to make sure that everyone has access to a more dignified life. And I'm not sure what the international community can quite frankly do. It seems to me that it is an urgent intervention. But I mean, the ceasefire and ending the violence has already been quite on the top of the emergency priorities, but it hasn't necessarily been enacted. So I'm not sure how we can even think about reconstruction today when we're still seeing such a large-scale destruction, unfortunately.
This is also assuming that the Palestinians in Gaza will be able to stay in Gaza, right?
Mm-hmm.
So then we're thinking about reconstruction, all of these social, psychological tools to help the children and the families within Gaza. But there's also the risk of being forcibly displaced outside of Gaza, which is already happening in North Gaza. So this is adding another layer of insecurity and generational losses actually over the years.
Absolutely.
I have another question from the online audience, from Farkunda, who's asking, bouncing off a question posed earlier, could you please expand on the last component of your typology about state and non-state actors, quote unquote, pretending to provide health services? In what ways, does this frame their long-term goal of gaining legitimacy, or are there instances of it hampering their existing legitimacy? And another question, is there any information by Fazia? Is there any information on human trafficking?
I think for Kunda's question, this maybe relates a little bit to the answer that I provided earlier, because this frames their long-term attempt at gaining legitimacy as a way of establishing themselves as able of providing social services, right, which is a core responsibility of state. It is showing that they have the means, the resources to operate these facilities, whether through capital, like human resources, etc., which I think is very important to try when an actor tries to legitimize itself. So not just through the monopoly of violence, but also through the monopoly on social service provision. And we've seen this also in, for instance, it's not really in the MENA, but in the Central African Republic, there were lots of groups, armed groups and armed militias like the Seleke that were also trying to provide healthcare to those that they deemed kind of to be part of their groups, as part of their territory conquest. And it hampers their existing legitimacy, I think, when it is conditioned upon a specific affiliation or allegiance. Because then obviously when an actor or a state differentiates and institutionalizes this differentiation between people that it heals and cares for and people that it does not care and heal for, this is already, I think, a sign of state failure and incapacity to rule, let's say, fairly. And in relation to human trafficking, I think this is definitely also part, I would say, of the weaponization of health, although it is quite different. But I would kind of inscribe this, and I do in my thesis, in the production of mass medical violence. If we're talking about human trafficking as organ trafficking, I'm assuming is kind of what the question is pointing at. And I mean, we've seen this unfold in the context of Israel's occupation in Palestine because of the large number of bodies of detainees that were returned, missing organs, etc. So that is definitely part of this instrumentalization of medical knowledge to inflict harm and to support political and military objectives instead of serving the actual public good and upholding medical neutrality.
Thank you, Salma. A lot of questions, a lot of interest. Is there any more questions from class? Okay, so would you say, Salma, I have a question. You talk about, of course, Gaza and Syria. Do you think we're going to see a pattern of armed conflicts or genocides taking place, which will have similar patterns, tactics? It's starting to spread, right? Sort of repeat itself. We've had it in the historical context of these attacks and the use of health or doctors as tools of oppression, tools of torture. Could we start thinking about sort of a conceptualization of war where these strategies and tactics are going to become very common patterns? And is norm making an urgent mission on the part of the international community to halt actually sort of this development of warfare, which is really reaching very, very dangerous aspects and very dangerous spheres where morality is completely sidelined, and it's acceptable for the international community to witness all of that in plain sight just by denying its existence, although everything is documented. Or how you mentioned international law as a way of resisting. What can we do as practitioners, as academics, as observers to counter that? Should we have more norm making? Should there be bottom-up resistance, grassroots activism? What should be taking place? Because the world is turning into sort of a normalization of these tactics and strategies.
Yeah, that's a really good question because unfortunately there definitely is such an erosion of norms and such a widespread today normalization of these attacks. And again, as I said, they're oftentimes rhetorically justified, and it just means that sometimes in the eye of the public, these are not even seen as violations, which I think anyone sort of looking very rapidly at social media today can see how many of these attacks are just considered to be targets, to be military targets, to be attacks on military targets, and to be completely normal within the conduct of war, either in counterinsurgency when they're talking about Syria, or like counterterrorism, or counterterrorism in the case of Gaza. And resisting that, of course, requires using existing legal frameworks, but also creating new ones that leave zero room for nuance and loopholes that actors can exploit in order to inflict this violence. Because I think this is also part of what's happening now, is that, for instance, hospitals are protected so long as they're not harboring, for instance, combatants, or as long as they're not used for military purposes. And any actor could say, well, I have an intelligence, for instance, that this hospital is used as a command center, right? We've seen this very recently. And so how can we deny that? In Gaza specifically, it's really hard because unfortunately, the international community or the international public opinion doesn't rely on local journalists for providing the truth. They're seeing it as obviously always being biased, etc. But there are no foreign journalists that can sort of also document these instances. In Lebanon, I think this was slightly different because, for instance, after accusations of Sahel hospitals being used as a bunker, immediately afterwards there were some journalists, foreign journalists, on the ground, and that obviously was enough in the eye of the public community to be like, oh, okay, so that means that this is a legitimate hospital. It's not an actual target. So we need to think about obviously the framing, existing frameworks, creating new ones that leave very little room for loopholes or for nuance that actors can exploit. More capacity building locally for health authorities. And as you mentioned, Marwa, this can and should be a bottom-up effort. And I think Syria has quite frankly been a very important example in that regards, because a lot of initiatives have sort of served to rapidly move hospitals underground, to try to build alternative models, to try to have local councils, to try to have local health directorates, just to make sure that medical services keep being accessible to people. Obviously, even these makeshift and underground hospitals were repeatedly targeted, but this just shows that there is a way of sort of trying to help. But ultimately, the burden or the onus of responsibility should not fall on people to try to find means of surviving and resisting. We should all, as an international community, be helping put an end to the violence that in the very first place has created such conditions.
It shows also all of these doctors and health workers in Syria who have really mobilized, right, at the risk of their own life, their family's life, that it's anything but a leaderless, faceless revolution. We were able to put names on those people exactly and how they managed to resist. I'm going to move on to another question from the online audience. Fazia is asking, as a former CHINS attorney, we in America care about abused children. Maybe this can be used as an angle framework to oppose normalization of abuse. Just an idea, adding to the aspect of how can we resist this abhorrent normalization of such practices. The idea that we focus on abused children, amputee children, deliberately killed, targeted children. Is there another question from class? No question? Yes, Sif, go ahead.
I have a question, but I'm not sure how squarely it falls within your research, but I'm going to ask anyway. I was wondering, we've seen how new technologies and especially AI has been used for destruction, but also there's like a huge potential per se in the health sector to provide, new ways of diagnosing people and giving them the treatments that they need. And so I was wondering, I mean, we've seen them, as a means of destruction mostly until now, and also potentially new ways of creating dependencies and control, oppression, and all of that. But what is kind of your outlook on that? If you have any research on that, if it can be used to somewhat safeguard the health system and also the health workers in conflict zones, or is it just the other side of the coin?
technology, not just as a tool of oppression and destruction, but as a tool of sort of saving, protecting civilians.
And both Syria and Gaza, these were very important tools for instance, remote medical interventions. So whereby, for instance, specialized surgeons abroad would guide non-specialized surgeons inside through what we call kind of like telemedicine or like teleguided medicine, so assisting them. This was especially the case in, for instance, Aleppo when it was under siege, because a lot of the remaining healthcare personnel that were able to still provide care were students, medical students that had not completed full and formal training, but that had to kind of operate, to perform complex surgeries, even though they only had 2 years or like 3 years in med school. And so the ability to assist them and guide them and have them talk to specialized doctors was very helpful, because it was under siege and no one was able to go in to actually provide that level of specialized care. And in Gaza, this was also kind of the case, because it's also important to note that Gaza has been chronically underdeveloped and developed when it comes to its health system. It lacks a lot of specialized care because of the restrictions, because of the blockade that has been imposed on the Strip. So there has always been a need for technological interventions to kind of help provide adequate levels of medical care. And so I definitely agree, technology isn't just a tool of oppression. In many ways, it can also be a way of resisting oppression, but unfortunately, it's not always, and oftentimes it's not sufficient, because when we're talking about health, we're really talking about complex interventions. We're also talking about the need for the delivery of medical equipment, the delivery of drugs, the delivery of vaccines. And so when we're lacking those supplies, there isn't much, unfortunately, that can be done, even with the best team of surgeons kind of assisting people from abroad.
On the supply side, you see also, for example, we know that drones are being used by Israel to target civilians, to destroy, etc. But in some instances, drones could be also used to deliver medical supplies when they are accessible. Of course, it's not always possible to have drones available.
Yeah, and what happened in Gaza also in a lot of cases is that the delivery, kind of the airship humanitarian aid, also ended up killing people. So I think it's also very important to be cautious about how these can be used and employed in, as you said, contexts where there are so many restrictions that prevent an actual access to humanitarian aid.
I'm going to check if there's, yes, last question from here, and I think this will be our last question for the day. There's no more questions from the audience.
Thank you. This week we've been reading a lot about the increasing securitization of health, especially on the state level, and how like the current narrative is that it is it enables states to protect themselves against others, whether this is developing countries or marginalized communities, even within the country. And when we securitize an issue, say health, it kind of legitimizes or enables the state or the actor to act upon it. And so you've talked a lot about like the weaponization of health, and I'm wondering in this context, like throughout your research on Palestine and Syria, if you've seen like the securitization of health being used as a legitimization tool to like continue these regimes, to continue the wars.
That's a really interesting question. I think in my research, I definitely do talk a lot about the securitization of health, but not in a similar manner. I'm more talking about the securitization of health as kind of elevating, right, health as a security problematic, and sort of also ensuring that it is accounted for when we're talking about security. But when we're talking about rhetorical kind of moves or power plays or frames that are employed to legitimize attacks against healthcare, I think maybe the concept that would more that would be a bit more appropriate would be more the militarization of health, because then it would kind of like be seen as a resource that is associated, for instance, with a military activity, and in which case sort of actors could justify them targeting it. But I think when we're talking more broadly about like health securitization, which again is also a framework that is not very comprehensive, in the sense that usually securitizing the lenses to health adopt a hierarchy of like health threats. They operate more to kind of protect the state and like national security, national survival. So for instance, what we've seen during COVID, right? Like that was an example of securitizing the pandemic. So it's often only used for infectious diseases. We've seen this, for instance, with HIV/AIDS, right, which was the first disease that was even discussed in the Security Council. And so those approaches oftentimes don't really center the individual, and they don't really cater to individual experiences of health and security, or to individual needs of security. Because, for instance, when HIV/AIDS was securitized, tuberculosis was the largest killer worldwide, but it did not garner the same attention, it did not garner the same funding, did not garner the same concern as HIV/AIDS did, just because of the mobility flows and how, because it was transnational, because there were vested interests in sort of framing that specific disease, because it was threatening other interests, whereas, for instance, tuberculosis is very much concentrated in the global south. So I think there are different also structural factors that determine what health issues are securitized, what health issues are not. And which is why it's also like a framework that could use a lot of reworking.
We read your co-authored piece with McCoy and all, and how you show the neo-colonial structures of health securitization, how it's elevated to the highest level when it's the interest of, you know, the big powers or Western powers, etc., and when it's sidelined, when it concerns the global south or the poorest countries around the world. So that's also an interesting aspect of this whole discussion. I think I'm going to thank you very much, Salma, for a brilliant discussion, brilliant presentation, and for answering all of these very challenging questions. A lot of work ahead of you, of us, to tackle these important developments. And I very much look forward to seeing your dissertation finished and published, because we will be learning a lot about such tactics and practices in the case of Syria. But that could be generalizable, unfortunately, to a lot of other contexts and situations. So join me in thanking.
Thank you so much, Marwa. It was such a pleasure to meet everyone, and I'm sure our paths will cross again in the future.
I'm sure of that. Absolutely. Thanks again. And we look forward to reading your policy briefs as well.
Thank you so much.
And thank you to the online audience for joining as well today. Thank you.